So, good morning all, and welcome. I'm Anne Charlet, and I'm on the board of Lupus Europe. I hope that you all had a very good sleep, so your brains could assimilate the information you absorbed yesterday, but that you have made room for a lot more information to come. Yesterday, we want to admit that we had some technical difficulties, and not everyone was able to join, which we really regret. Hopefully, we've taken care of those difficulties today. And at any rate, those two sessions from yesterday were excellent sessions, one on wearables and the other on vaccinations. And they were very well attended with a lot of interesting questions. They've been recorded, and the one on wearables is now up to be viewed on Facebook. And the second one on vaccinations will be available after lunchtime today. So if you could go to the next slide, please.
Yeah, it's coming.
That's Anne-Marie. Okay. Yeah, so sorry, those are the ones from yesterday. And they're up and they will be live. So today we have a very full agenda, as you can see. And here's the program. We'll start at 10:30, the latest, it's now, latest news in lupus, all about the latest developments. Later on at 2 o'clock, we'll have information about diet and rheumatic diseases. Then at 5 o'clock, we have a session on fatigue, something that maybe some of you know about. And then we'll have a session on exercise, also at 5 o'clock. These are two parallel sessions. And then importantly to note, at 7 o'clock tonight, we have an aperitif, a meet and greet. And I just will be running that. And I'd like to make a quick little mention that please try to remember to have your snacks and drinks ready when you come. They can be cocktails or mocktails or whatever you want. And don't forget to have your butterfly at least attempted to be made. Oops, they're in front of my face, right? That's how we see them. And origami butterflies. And we'd like to have you at least attempted to have made them. They're over here in front of my mouth. There we go. And you have the, thank you. We have the instructions, at least try to make when the instructions and the link to a video are in the slides that you received in the email this morning. So maybe at lunchtime you can try and make those. We'll see you then. Thank you very much and have a good day. And over to you, Anne-Marie.
Yeah. Good morning, all. This morning, as Anne mentioned, we have the latest news in lupus. Is a new day dawning. Professor Ronald from Vollenhoven will present it, but I will have some logistics and a bit of housekeeping rules. As you can probably see, the session is not only followed by those joining in our room in Zoom, but is also followed by live stream on Facebook. So more people will be listening and watching than the number shown in Zoom. And we will start shortly. And I have some rules which will appear. Please be ensured that your microphone and video has been turned off. Please turn only your microphone and video on when you are speaking. Please be aware this session is recorded. Only use the raise hand function at the bottom middle of the screen if you absolutely need to get our attention during sessions. We will respond in chat. Please use the chat function to ask any question or for any comments you may have. If you are on Facebook Live watching, you can leave your questions below the live stream, and they will be sent to the chat and asked after the presentation. Please be patient with us. We will ensure your questions are answered. If you have any technical problems, try logging out from Zoom and logging back in. These are the rules. And then we have a quiz. And to prickle your brain. And questions are, I don't know who is sharing the quiz. Yeah, which of these words from lupus research have you heard of before? Check all relevant boxes. Baricitinib, NIP, anifrolumab, B-cell depletion, JAK inhibitors, interferon. Please start submitting your questions. Your answers. And I would like to know when people have completed, and then I will go to. So most of people have heard of interferon, and then B-cell depletion is the second one, and JAK inhibitors is with anifrolumab is third, and where Reade has been the smallest one. And then we go to the next slide. Do you know what all of them mean? Yes, I have a comprehensive understanding of all terms. I know what some of them may mean, but not all. No, I haven't heard any of them before. It's very technical, and we try to get you to know everything. So some are known and some don't know, and a few know all terms. Now, maybe you know more after the presentation. Now I will introduce you the speaker of today. The speaker of today is Professor Ronald van Vollenhoven. For not Dutch speakers, it's a difficult name to pronounce, but I can pronounce it better because it's Ronald van Vollenhoven. But international, you probably pronounce it differently. He is the chair of the Department of Rheumatology and Clinical Immunology at the Amsterdam UMC, the Netherlands. He also is the director of the Amsterdam Rheumatology and Immunology Center, RRC, and chair of the Rheumatology Research Council at Reade in Amsterdam. His research interests focus around the development and systematic evaluation of biological, and this is a word I find difficult to pronounce, but it's immunomodulatory treatments for the rheumatic diseases. He is also co-author with whom you all may know, Professor Laurent Ornault, of the Handbook of Systemic Lupus Erythematosus. He's the editor-in-chief of Lupus Science and Medicine, member-elect of the EULAR Executive, past chair of the Swedish Rheumatology Society, Professors Council, co-founder of the IRBIS registry for biologics in SLE, the Serera registry collaboration, and the North Star collaboration for Nordic trials in the rheumatic diseases, and the initiator of the Treat-to-Target-in-SLE and DORIS initiative. So you can see he's very active in research for SLE. And now he's going to talk to us about latest news in lupus, a new age dawning. Ronald, I will invite you to start sharing your slide. I will stop sharing and you can start sharing.
Thank you very much, Anne-Marie. That was very kind of you to introduce me with such enthusiasm, and I hope that I can deliver a little bit on the promises made in the introduction about my presentation. Of course, I won't be able to cover everything. There were too many things in there, but I'll try my best. I'm going to see if I can share my screen. It's the technical part that always makes me a little bit nervous in the digital age. It's always easier if you can do it live. Let's see, I need to go to share presentation mode. And I have to go and I have to check here. Anne-Marie, can you confirm if it's showing the screen now?
Yeah, it's okay now. You can.
Very good, thank you.
Thank you.
So I'm very happy to be here. to speak about some news from the area of lupus research and also how lupus can be treated. And I'm going to try to convince you in the next half hour so that there really may be a new day dawning for lupus, for patients who suffer from lupus and for the treatment possibilities. And so it's a really, I think, exciting time to be looking at this, although you would always like it to go faster. You would always like it to be immediate. Would it be available today? Why not tomorrow? And I know, and it always takes a little bit longer, but it's moving. Here are my disclosures. And well, as already mentioned, I give you greetings from Amsterdam. I know we are all scattered around the world these days when we do a presentation and when we're at congresses. It's not a location. We are maybe in our home. Maybe we're sitting somewhere in a public place and watching. So you never know. But I speak from Amsterdam. It's the fall. The autumn has started. It's outside. It's a bit dark, but there's no rain, not yet. But here in Amsterdam, we have several medical centers and they are collaborating more and more. We had the AMC and the VUMC, which have now merged in the Amsterdam UMC. And we do indeed also have the Amsterdam Rheumatology Center collaboration. Now, the topic, of course, is systemic lupus erythematosus, which is funny. It's called this long name, or SLE for short, or many times people just say lupus. And that's not exactly accurate because lupus, originally, that was the skin manifestation. And then somebody realized back in the 19th century that it wasn't just the skin, it could also be inside the body, and called it systemic lupus and erythematosus, meaning red. And this is funny because the disease has two animals. One is the wolf, because lupus means wolf, and the butterfly, because, you know, the butterfly rash. And I think it's so funny that this one disease has two very, very different animals connected with it. And what could be more different than a big, dangerous, predatory animal and a very delicate butterfly? And yet this one disease has these two animals connected to it, and it illustrates how this disease is also very, very different from one patient to the next. It is very heterogeneous. It has very many different manifestations. It can be in the skin, like I mentioned, or in the joints, in the heart or the lungs. It can be in the muscles, the bones, the nervous system, any place you want to mention. That is a big challenge also, because as we were sitting here, and I think many of you watching today do actually suffer from this disease, and you may not have the same experience as the next person because your symptoms are unique to you, and then the next person would have different symptoms, but there are also some things that we all share in common. So this disease does have many different clinical manifestations, meaning many different ways that you experience it. And what the doctor will do is do blood tests, and they will see that it also is a disease with lots of autoantibodies. And that means these are the antibodies that are supposed to protect you, but in fact, they are attacking your own tissues. And this is very characteristic of lupus, that it is a disease where there is not just one, but usually a whole bunch of different autoantibodies that should not be there, but they are there. The question is why, but we do understand that they contribute to this disease process. So this is an autoimmune disease, the immune system acting against itself. And there are many autoimmune diseases, not just lupus, there are many other ones, but many times it's the same principles that apply. So most of the autoimmune diseases are chronic, or they could be recurrent. And this is true for lupus. Some people have symptoms all the time, and others actually are okay for a while, and then they have a flare. And then once the flare has gone away and they've maybe been treated and the flare has gone away, and then they're fine again for a while. So it can be chronic all the time, or it can be recurrent where it comes back. And fortunately, mostly the autoimmune diseases and lupus are not life-threatening, although in some instances they can be. But the real problem is that these diseases, and certainly lupus, is associated with pain. There may be functional losses so that you cannot do the things you want to do. And so that makes it a reduced quality of life. Then you have obviously less pleasure and less possibilities and options in your daily life. And that's the real tragedy of it. And that's what we have to do something about. And this means that we also have to take a long-term perspective, because we cannot just look at today, we have to also look into the distance. So the EULAR is the European Rheumatology Organization. It actually has changed its name. It's now the European Alliance for Rheumatology Associations or something like that. But we just call it EULAR because that's easier. It's a big European organization, and they look at medical diseases in the field of rheumatology, including lupus. And then in this case, they have actually had published some recommendations for lupus. And these are all very sensible things that if you are a doctor, you understand them. And certainly if you are a patient, you also, I think, will understand and agree with these. But let's go through them just quickly. That obviously the survival is always important. But like I said, usually that's not so much the issue. Prevention of flares, that you really would like to be able to not have the flare. Then there is the GC dose, that's the glucocorticoids, that's like prednisone and other or steroid treatments, and that it is really a goal of treatment to try to minimize it. We do need to use them. We do need to use prednisone. We need to use the other steroids in the treatment of lupus, but we try to minimize it because they also have many side effects. The renal involvement, that's the kidneys. We would like to be able to detect it early so we can treat it more effectively. And then achieve the lowest possible disease activity. And that's really key. We would like to keep the disease as much under control as possible. And it actually mentions here already remission, which is a concept that I'm going to talk about more, that it means the disease is really, really well under control. Then to prevent damage in the organs, that's of course very important. To try to improve the health-related quality of life, that's the HRQOL. It's the quality of life, really. And that is what you, of course, want to have. You want to have a good quality of life. And you want to be able to also make sure that there are no other diseases, comorbidities. So there's lots of goals in the treatment. And one of the challenges for both the patient and the doctor or the nurse can be to balance all these different goals. So we can ask the question, how are we doing in lupus treatment today? And we have to sometimes be able to look in the mirror and be honest with ourselves, not like this cat who looks in the mirror and sees a lion, but we would like to be able to look in the mirror and really look at, okay, what it is really like. And then I have to be honest with you, it's not so great. So this is a study that was done a number of years ago in Sweden. I was working in Sweden then, now I'm working in Holland. And in Sweden, I did a study together with Christine Bexelius, and she surveyed patients who suffered from systemic lupus erythematosus. And one of the questions we asked them was about the quality of life. And you can measure quality of life with different questionnaires. And this particular questionnaire gives you basically a number. And if it's 0, that's really, really bad quality of life. That's like being dead. And 1 is very good, it's excellent quality of life. So it's always between 0 and 1. And the average for lupus was 0.64. And that's not so good, it's the average. So some people do well, some people are good, but some people don't do well. And the average it's just so. So of course, we're happy for every individual person who does well, but we cannot say that the result overall is so great. So the question really is, how can we do better? Now, there are basically 2 ways of doing better if you treat the disease. One is that you use the treatments that you already have, but in a better way. So a better approach, better strategy, or you can hope for better medications. And I'm going to talk about both now. I'm going to first talk about the medications we already have, but can we use them in a better way? And then next I'll talk a little bit about new treatments that are coming. So to better use the treatments that already exist, many experts feel that we should be doing something that's called treating to target. And treating to target means that you don't just give a treatment to the patient and say, okay, let me know, if you need me for anything else. But you say, no, let's together with the patient decide what the target is. What are we really aiming for? What is our goal? And you discuss it with each other. And then you say, okay, this is a treatment goal. Now, what are we going to do to try to achieve it? So you do something, and it could be all kinds of things. It doesn't have to be medications, could also be some change in the life, or some physical exercise. I'm just saying, but you do something to try to get to this goal. And then after a certain amount of time has passed, you evaluate to see if it actually did happen. And maybe it did happen and it's great, but what if it didn't happen? Then you have to try something else. So this is treating to target, and treating to target comes from areas such as blood pressure. You know, with the blood pressure, 30 years ago or 40 years ago, doctors would say that, well, you know, let me know if you have a problem with your blood pressure. But nowadays, doctors know that, no, you have to check the blood pressure and you have to say, this is what it should be. If it's too high, we're going to do something about it because of the long-term consequences. And that's a very simple explanation, and blood pressure is much simpler than lupus. So what is better maybe to compare lupus to something like cardiovascular disease. You know, people talk about how they can make all kinds of changes to try to prevent heart attacks, stroke, and these are things like checking the blood pressure, but also overweight, to do something about that, smoking, of course, not smoking, and also what you see in the left upper corner is the checking the blood sugar. So cardiovascular disease is more complex. It's a little bit like lupus. It has different aspects. And treating to target works in cardiovascular disease. So many of us feel that in lupus, we should also more and more try to do treating to target. That's a strategy. One of the things that we also need is a definition of remission. Remission means you don't notice the disease anymore. I mean, you might have it, but you don't notice the symptoms. It doesn't cause you any pain. And, you know, hopefully that means that it's also going to stay away. So that is a very, very desirable state. We really would like to achieve that. And sometimes it is achieved thanks to the patient and maybe also to the doctor, but not so often. But we want to achieve it more often. So, but the question was also, is there a definition of remission? And so we worked with a large group of both patients and specialists, and the patients were also including from Lupus Europe to come up with a definition of remission in SLE, or the DORIS project. And we did in fact have a definition that has now been finalized. It includes how you're doing as a patient and the assessment. It does include some of the laboratory tests, which is always important, but not the autoantibodies, because we don't think they have to go away. You could actually be doing very well and even still have the autoantibodies. And then the duration, that's a bit of that you want it to last as long as possible. You would like it to last for the whole life of the patient, this remission, but it may not be possible, but then at least the longer, the better. So that's a little bit about how we can do better in terms of the strategy for using the medications that we already have. But what many of you have heard, and which is true, is that there's also a lot of exciting developments in terms of new treatments being developed. And you can in the background probably hear my clock chime, because it's a few minutes ahead, because we're not quite at 11 yet, but this is my clock. So I'm going to talk about the medications. Not so much existing medications, but new medications. But where do new medications come from? How do we even, how can you start making a new medication? Well, you have to understand what's happening. And that's why I want to show this very complicated cartoon, which indicates many of the things that are out of balance in the immune system in somebody who has lupus. So the immune system is very complicated, and it has to be complicated because it has to protect us against all kinds of things. It has to protect against bacteria and viruses and fungi and all kinds of things. And so it has to be complex. And then the complexity also makes it that it can go wrong in many different ways, but also that you could try to treat it in different ways. And that's the nice thing about immunology nowadays, that we can actually target specific parts of the immune system. We can say, okay, this is what's wrong. Let's try to block it right there. And that is where the biological treatments come in. And many of you have heard about biologics. And what are biologics? Well, they are medications, but they are very complex molecules, complex structures. So they are not easy to make. That's also why they're expensive. But what's nice about them is that you can actually decide up front what you want it to do. So the target for the biologic can be selected. And then we also understand how it works, which you would think, don't you always understand how it works? But actually with older medications, we sometimes don't really understand how they work. We know that they do work, but we don't exactly know how. But the biologicals we understand quite well. And that means that we can also predict more or less what the side effects could be. And that's all very good about biologicals. But what you also have to know about biologicals is that they work for some patients, but they don't work for all. And like I said, they are expensive. But if you take the whole picture of biologicals, then biologicals have really helped bring hope and also real improvements for patients with many autoimmune diseases. And that would include lupus. But in lupus, I think we're just starting to see that now. And I'll give you a few insights into that. So I already showed you this complicated cartoon of the immunology of lupus. What is wrong with the immune system? Why is this happening? And part of it, this part where the circle is around, has to do with a certain kind of white blood cells that are called B cells. So we all have B cells in our bloodstream, and they're very good cells to have. But like I mentioned, in lupus, many things are out of balance, and the B cells in lupus may be overactive. And so many thought that we could slow down the B cells. And many years ago at the Karolinska Hospital, we treated a young woman who was, she had bad lupus, and especially in the kidneys. And these are slides made by a microscope from a biopsy from the kidneys. And you have to be a specialist to be able to analyze it. But you can sort of tell that on the left side, there's a lot of the dark dots, and there's a lot of it's very compact, and it shouldn't be that way. This is a kidney that's badly inflamed because of lupus, and then she was given a treatment with a what was then still an experimental medication against the B cells, and it actually got a lot better. On the right side, you can see that it looks more the way it should look. And this was just one experiment, really, or a test that we did, which worked out very well for this one individual. But later there was a treatment developed called belimumab, which also slows down the B cells. And belimumab was approved about, I think it's almost 10 years ago now, for the treatment of lupus. So it's a biological, so you have to give it as an infusion or as an injection. And it can work very well. It turns out that there are certain indications in the blood tests that will tell you that the patient has a greater likelihood to have benefit from it. That is useful to know, and it works slowly. So if this is ever discussed with the patient and their doctor, they would have to say that, well, let's try to use belimumab. It might work well, but you would have to wait for 3 to 6 months to be able to tell if there was a real benefit. But this has been used now over quite a number of years and has been useful for some patients very much so, for others less. But what is nice is that there is this special problem of the kidneys. If the kidneys get involved in lupus, it's usually pretty serious. And it turns out that it was only realized this year that this same medication, belimumab, also really works well for lupus in the kidneys, lupus nephritis. And this was a study that was published, but this has now also been approved by the regulatory authorities, by the European Medicines Agency. So you could actually say that nowadays, if you would suffer from the lupus in the kidneys, the lupus nephritis, then this is also a treatment option that could be considered. So it's a little step forward, I think, for that particular manifestation of lupus. So I talked about how the B cells can be out of balance in lupus, but there could be other things out of balance. And the other thing that could be out of balance is cytokines. And so maybe you wonder, what is cytokines? And cytokines are signaling molecules. They send the signals in the immune system. They will communicate between the different cells. And those could be out of balance. And then there's a medication called baricitinib, or a JAK inhibitor. The baricitinib is the name of the drug, and what it does, it's a JAK inhibitor. And that actually, it turned out in a trial to also have a benefit. It was in a small trial, a phase 2 trial, seemed to show benefit. So this is being tested now. And this could, if it gives positive results, also be a very interesting treatment, because this is a little bit different. It's not really a biological, but it does have some of the characteristics, and it's a medication that can be taken as tablets. It's already being used for the treatment of rheumatoid arthritis. And this might also become available for lupus if the larger trial is indeed positive. But perhaps the most exciting news now in lupus is about something that is in a different part of this cartoon, in the middle part, which is called type 1 IFNs. IFNs is interferons. Now, I noticed in the quiz before we started that many of you had heard of interferons, and that is good. Interferons have been around for a long time. They're called interferons because they interfere with viruses, so that's good. It's a good part of the immune system, and interferons can be very useful to have. But as many things in lupus, they can be out of balance. And it has turned out in many patients with lupus, there is way too much interferons being produced. So some clever scientists said, well, if that's the case, then we could also try to block the interferons or slow them down. And that has been tested now in clinical studies. And these are results from a study that was already published a few years ago, where patients were given a medication called anifrolumab, which blocks the interferon. And as you can see in the picture, this was one individual who suffered from bad lupus of the skin. And with this treatment, it improved quite dramatically. And the graph on the bottom will show how it was for the average for all the patients. And you can see that there is a purple line and a blue line, and then there's a gray line. And it's the purple and the blue are both the anifrolumab line, which is the medication. And the gray line is the placebo, which is the patients who did not actually get the treatment. They were given something, but it was just to keep it blinded. It was not a real medication. And you can see that there's a big difference between, on the one hand, the blue and the purple line, which are almost the same, and then the gray line, which is very different. So this suggested that the medication anifrolumab works quite well, but it was a small trial. It was necessary to confirm it. And then 2 new trials were done. And these were both published in the past year. These trials were done in the same way. The one on the left, as you see, there's 2 lines, the blue and the red. And there's not so much difference. So that trial was a bit disappointing, but the one in the middle, TULIP-2, you can see that there's a difference between the lines. And that actually confirmed again that anifrolumab does have an effect in lupus. And what has happened is that the American authorities, the Food and Drug Administration, or the FDA, they've actually approved this. So they have said that the patients in the United States can be treated with this medication. In Europe, that approval has to come from the EMA, the European Medicines Agency. They are currently investigating the files. They don't always reach the same conclusion as the American colleagues. That is a fact. So we don't know if they're going to approve it. You would think so, but it's not easy because they also have to consider any risks and side effects. And they could say that, well, they think that the risks are still a little bit too high. But on the other hand, the effects seem to be good, but we'll see what the EMA says. Hopefully, to me, it's hopefully because I think always better if you have another treatment, and anifrolumab could be used also in a few months' time in Europe. And what is it? It is an infusion, so you have to go to the hospital and get it infused as in the arm once a month or every 4 weeks. And then if that is given to the patient, then they hopefully will be able to have this interferon slow down, not too much interferon anymore, and then the lupus gets better. So that's what we're hoping for. It is exciting that something that is very new is being developed because it's also a very different principle. It's not just yet another one. This works in a very different way. So we have hope for this. And the last slide on this is that this is a small trial that I was myself involved in that is done in a different way also to slow down interferon. So with that, I'm actually going to reach my conclusion slides because I covered a lot of ground, and fortunately we have some time also for questions. So, but I want to say that we are definitely starting to understand the way that the immune system is out of balance in patients who suffer from lupus. And then we can target some of those components. So if the B cells are to blame, then there is already the treatment with belimumab. It's also effective in the kidney disease and lupus nephritis. So that is something that is already there and that we can still use, maybe also use more. The JAK inhibitor, the baricitinib I mentioned, that was in trial and it is still in trial, and hopefully we'll get to find out if it really works in the next year, I would think. And then interferon, as I mentioned, very interesting and very new, and anifrolumab now approved in the United States, may also get approved in Europe, and then it would be a new treatment for lupus. And of course, there's the treatment I mentioned briefly that I was involved in called BIB59, that is still in an early stage. So if you take it all together, look at the combined result of all these efforts, then I think it is fair to say that in the next few years, there will be really very, very different treatment possibilities and treatment strategies for systemic lupus erythematosus, which brings hope that many of the patients, many of you, will be doing better, that it will be more and more successful to keep this disease under control, to prevent the flares, to give the disease activity no chance, to keep the disease under control, to get a better quality of life. And with that hope, I will end here, and I'll be happy to take any questions. Thank you very much.
Thank you, Ronald, for your very interesting presentation. And you can stop sharing, and I will start sharing my screen. I cannot see the question, so if anyone else will pop up the question.
I can see the questions, Annemarie.
No, I can't because I have to.
Yeah, but I can see them. So shall I read up the questions and answer them?
Oh, maybe one of our other board members can.
I can read them, and then I'll put them to you, Ronald.
Oh, okay, thank you.
Okay, so thank you for a really great presentation. It was wonderful. I think you answered a lot of our questions beforehand. So I have a question from Anne. Do some patients sometimes get drugs approved by the FDA and not the EMA? Is that possible? I think you kind of alluded to it.
Yes, I saw that question. So is it possible that a drug is approved in the United States and not in Europe? Yes, that can happen. And is there then a way that the patient in Europe can still get that treatment? And the answer is, well, yes, because most often, yes, because the companies that make these drugs usually have the so-called compassionate use programs, which means that if the doctor says that, well, you know, for this particular patient, for this unique patient, I do feel that that treatment that is not approved in Europe is nonetheless the best possible treatment, they can apply for that. And then it is actually possible to get that treatment. It's not an easy process. And especially with a new drug, there's often a lot of bureaucracy involved, but it can be done, yes.
Thank you. So Andreas wants to know if you've seen any research in the area of genes for SLE. So gene therapy.
Absolutely. Well, genetics of lupus have really been studied already for a long time. And it's a bit frustrating because there are very many genes that contribute to the risk for lupus. There may be more than 100. And they all contribute just a very little bit. So I think that what the genetics is telling us that lupus is also to a large extent a disease of bad luck, having, you know, you inherit the genes from your father and your mother. And then if the combination works out a bit, unfortunately, then you can get this disease. So that is what the genetics seem to be telling us. But the more important thing is that actually quite a lot of these genes are involved in the immune system, which makes sense. And that's also why the immune system gets out of balance. And the interferon story, which I mentioned, there's a lot of research showing that interferon is particularly out of balance. That actually is supported also by genetics.
And is there any, do you know of any research into gene therapy for lupus?
Sorry, research?
Into gene therapy.
Oh, gene therapy.
Mm-hmm.
Well, no, I don't think so, because the problem is then that you can fix one gene. If there's one gene that's abnormal, you can fix it with gene therapy. But in lupus, there's not one gene that is completely abnormal. It's just that very many genes work out a little bit in the wrong combination. So I'm afraid that that's not going to be, not anytime soon, at least.
Yeah, shame. So this is actually for myself. So outside of anifrolumab, is there a new product you hope will be the next successful one?
Well, I emphasize anifrolumab because I think that's right now the biggest development. Of course, we're also still looking at other possibilities. Like I mentioned, the possibility of the JAK inhibitor, baricitinib, and some related medications could also have a role in lupus. There was a question about a drug called voclosporin, which is actually approved in the United States for the treatment of lupus nephritis, of lupus in the kidneys, not of lupus in general. And that could also be a step forward. That could also contribute a little bit. So there are some other developments, and people are always looking for, is there something that's radically different that can be done? At this point in time, I think that many other developments that are interesting are still at the very early stage. So it's hard to predict which ones are going to be coming to real, to real fruition.
Okay, thank you. So there's a question from Wendy. Can you know in advance what pathway to try? Can you measure the B cells and the interferon in the tissue? So I think it's about biomarkers and
Yeah, I'm so happy to get that question because I really like to talk about this. As I mentioned, I started by saying that patients they're all individual patients, and they're different. If one person has lupus and the other person has lupus, doesn't mean they have the same thing. It could be very different symptoms, very many different manifestations. But the same is true on the inside. If you look at the immune system, and then we are now trying to make the treatments more individualized. So we would analyze the immune system, look at, okay, what are the problems here? What is out of balance? What is most responsible for this disease? And to target it. And we're getting a little bit in that direction. I mentioned it very briefly that with belimumab, we actually know that some blood tests can suggest that this is that belimumab for this patient might be the right thing, but maybe not for the next person. With anifrolumab, that's definitely also being looked at. And there's one marker that has in preliminary studies suggested that it's related to the effect of anifrolumab. But we need more information about that. It's definitely something we would like to be able to do a test and say, okay, this is your test result. That means that this is the best treatment for you.
Yeah, avoid the trial and error that many of us experience at the moment.
Exactly.
I know that a lot of research is done into biomarkers, and we're hoping it will show good results.
Yeah, and personalized treatment.
Yeah, exactly. So Juan Carlos is asking, is it better to live with some level of joint and muscle pain to reduce the amount of steroids, or should one aim to eliminate all symptoms?
Yes, I think that is the hard part, right? You can control many lupus symptoms with prednisone or with other steroids, but then you get the side effects from the steroids.
Yeah.
And it's a balance that you continuously try to adjust. And I cannot say, okay, it's always better to just tolerate the pain. Who am I to say that? But I think that's part of the discussion that we should be having as doctors with the patient. What is your most comfortable level that we can achieve without doing damage by giving you too much medications?
Yeah, constant balance. Yeah. So Magdalena is asking, may the mRNA technology be helpful to find therapy for lupus?
Well, mRNA technology is actually always used to make these vaccines against COVID, right? But I don't know if that would actually help against lupus. I'm trying to think if it's possible, because that is the technology that they actually make. So you stimulate the body to create the antivirus antibodies. Now, I don't know if we could apply that to lupus. I'm also not very involved in that kind of science, so that I would have to ask the question of somebody else.
Yeah, maybe it's more for an immunologist than a rheumatologist, but it's an interesting question. So we have a more personal question from Aldovina. So moving a bit away from your presentation, how do you prove to your doctor that you need to reduce the level of plaquenil? So her weight is 48 kilos and she takes 400 milligrams of plaquenil daily, and she's been doing it for more than 5 years. So do you have any good tips on how you convince your physician to change your treatment?
Okay, that's a little bit unusual, because I think, if I understand the question, the patient has a relatively low weight.
Yes, she
and
wants
has
to
taken a rather
less.
high dose of plaquenil, and she herself, I guess it's a she, has realized that may be more than is really needed and would like to reduce it, but the doctor apparently does not agree with that. So it's a little bit in the doctor-patient relationship. And of course, I think there's very widespread agreement that we should always make these treatment decisions together with the patient as a partner, and to go into the discussion. And it's very unusual, because usually it's the other way around, but so I don't know what kind of advice I could give here, other than to really start the discussion. And if there is any doubt, the guidelines for the treatment of lupus will actually say that the dosage that should be aimed for is 5 milligram per kilogram. So in this case, that would be something like 240 milligrams, which is much less, of course, than 400. And
So
I don't know
maybe-
if there's any particular circumstances that has led to this rather high dose of Plaquenil. So I think it has to be in the dialogue, but it's an unusual situation.
Yeah, Claudia is saying she shared the guidelines and the studies with her doctor, and he agreed to lower her dosage. So maybe that's the way to go, to actually share the guidelines. So Anne-Marie would like to know about the JAK inhibitor. She learned that it works also for skin diseases. So what's it different with mycophenolate if you compare it to JAK inhibitors?
Yeah, well, so we still have to find out if the JAK inhibitors work in general, and then if there may be one or other specific manifestation where it works very well. But it could work for the skin disease. And then the difference between JAK inhibitor and mycophenolate, probably the most important difference is that the JAK inhibitors work much faster. So this is nice about that particular group of medications, that you don't have to wait so long before you know if it's helping you. Because that's a big disadvantage of the older treatments like mycophenolate, like azathioprine, like methotrexate. They can all work, but it takes several months before you know. And then, of course, you can find out after several months that they don't work. So it's very frustrating. I think with JAK inhibitors, we tend to see a pretty quick effect that within a few days or weeks, people say, yeah, I noticed this is helping, or not, but then at least you know.
Yeah. Okay, so a few questions is coming in. So Amy is asking, you talked about voclosporin before. Does it work fast in comparison to azathioprine?
Gosh, I would say that it may work a little bit faster on the specific manifestation, which is called proteinuria, which is that you lose proteins in the urine, which is a dangerous complication in some patients who have lupus in the kidneys. And for that complication, voclosporin probably works faster. For other manifestations, it's probably not so different.
Okay. So Anne is saying, you said that biologics work and told us how they work, and now there's only one biologic approved, but it's also found to be effective in the kidneys. So is it possible that other biologics might be discovered and useful for other uses?
Absolutely. So biologicals are usually developed for one particular disease, and then we discover that they can also work for other diseases. Belimumab is interesting because it was developed uniquely for lupus, and it has been approved for that use, but you could ask the question, is it not also a good treatment for patients with some other autoimmune diseases? And that's sometimes being tested. And the other way around, there are many medications that have been tested first in patients with rheumatoid arthritis, and then later they were found to be also useful for lupus. That was true for some of the older medications like methotrexate. So with biologicals, that's happening also. I think, for example, that anifrolumab, if it's approved for lupus, that's just the first step. It may also be later approved for other autoimmune diseases. What has not happened so much is that the treatment from outside lupus was then also used for lupus patients. It happened with one medication, I can tell you, with rituximab. Rituximab was approved first for the treatment of some kinds of cancer in the blood, lymphoma, and then later also for rheumatoid arthritis and for vasculitis. And it was never approved for lupus, but many specialists still feel that it can be good for some individual patients with lupus, and they sometimes use it in certain specific situations. So it sometimes happens, but not so often. We hope maybe to see that happening a little bit more.
Yeah. So Anne, do you want to unmute yourself and ask a follow-up question?
Sorry, my question was really that, thank you for the answer. It's interesting. How does it happen? And maybe it's because there's so many genes involved in lupus, but how does it happen that you work on a use, one specific use, a medicine for one specific use, and that you find out that it works for other things? And is it because, I'm just confused about that. How can it happen that you develop for one thing and then it is useful for something else, and you don't know that? When you say biologics, we know exactly what we're creating them for.
Yeah. part of it is unfortunately also how it works in the process between the companies that, well, first the scientists who discover something and the companies who have to do the drug development process and the regulatory authorities. Because if you, let's say that you have a brilliant scientist and who has come up with a great new idea, and you have a lot of money, so you can start a company to make it as a drug, it takes a lot of money. And then you say to the regulatory authorities, well, I would like to develop this as a drug for all kinds of diseases. They will say, no, you have to tell us exactly for which disease it is. So it's part of the regulatory environment, and that's why I actually, because I'm asked often by companies, well, we have this drug, but for what disease could it be good? That's a question I get, and I usually tell them that there are certainly many diseases for which it could be good, but you also have to prove that it is good, and that requires big studies, and those are time consuming and costly. So then usually we have to narrow it down to just one or two to say, well, this is what we're going to test. So it's very much because of the way it's practically done. Now, I've myself been interested in something called a basket study, which means that you can do a study with a treatment and study it in different diseases at the same time. Some have done that. There was a French study not too long ago where a drug was given to people with different autoimmune diseases, including lupus, but also vasculitis, Sjogren's disease, and others. And it was published, and people thought it was interesting how they did it. But in the end, many people said that, well, but now we still don't know because the numbers of patients end up being quite small in each disease. So it's a good question, but it's very difficult to see a way out of this conundrum. And I think that for the current time and for the near future, we will probably still be seeing that the treatments are developed for one particular disease.
Thank you. So we have 3 questions left. So one is from Alain, who wants to know, mycophenolate is still off-label for lupus. Do you think we can use the drug repurposing process of EMA together, patients and doctors, to have it on-label? And we're thinking about working together with Lupus Europe and the doctors.
Yeah. So I think for those who have heard the question but wonder what it is really about, so sometimes the drug is used already for many years, but it's never actually been approved by the authorities for various reasons. It could be that nobody has taken the time and the trouble to get it approved. That was just a happenstance, or it could be that it was actually tried and failed. And with mycophenolate, it's a little bit of both. And I don't know if there's so much interest on anyone's part to try to do that now, because the question is also, what would the difference be? Because mostly with a drug like mycophenolate, which is not extremely expensive, let me put it that way, the insurers will usually not have a problem if patients with lupus are treated with it. At least I've not heard of that happening. But so in that case, I'm not sure if it's worth to go through what is quite a lengthy process to do that.
We know that some patients have issues.
I've had that problem that it was not.
Yes, it wasn't reimbursed.
Oh, that's very unfortunate, and we probably are looking a little bit at different situations in different European countries. It's not one size fits all. If there's a clear need for approval to get this to the patient, then I think we need to look at that issue, and hopefully we can work together between patients, healthcare providers, maybe the manufacturers and the regulatory authorities to try to solve that. It's a very good point.
Yeah, thank you. I know, Zoe, that we have a few questions from Facebook.
We do indeed. We have a question from Laura on Facebook, who is asking, is there any new research ongoing about the treatment of the neurological psychiatric involvement in lupus?
Absolutely. So the neurological manifestations and the psychological or psychiatric manifestation of lupus, all those things that are so hard to grab, the anxiety, the depression, also the fatigue can be a part of that. And also more even serious things like changes in the thoughts or stroke. And they're all part of the studies that are being done with these new medications. But one of the hopes that we have, which is it's not entirely clear if that hope is fulfilled, is that there are specific lupus manifestations in that realm that will respond even better to these kind of treatments. So we hope to see that, and there's some who believe it. Research, yes, I think there is some outstanding research being done in some centers across the world, especially in New York. There's also in Stockholm and in Uppsala, especially in Sweden, into these neurological manifestations of lupus. And I do think that the neurologists have become very good at identifying autoimmunity as a problem in many different neurological states. And some of those might also apply to patients with lupus.
Thank you. And then we have a question from Pascal on Facebook, who is saying, thank you for this great and clear presentation. Are there any issues for patients having been treated with corticosteroid for many years? Are these treatments complementary? Can corticosteroid be replaced? Thank you.
Well, thank you for the kind comment. And the medication that you mentioned, corticosteroid, is not familiar to me, I'm afraid.
It is, just by Googling it, it appears to be a steroid.
Okay, so if it's a steroid, and that's the problem, of course, there are so many different steroids being used that sometimes the names are unknown to me. But yes, treating with steroids for many years is a concern because the side effects of steroids, they accumulate with time. So the longer you use them, the more risks you have. Now, that doesn't mean that you're always going to have a side effect. Some people can take small amounts of steroids for many, many years without negative consequences. But we try to minimize it for that reason. And I think it is very important from time to time to also check, is there any evidence that this is now leading to problems, for example, with the bone health? You know, the problem with steroids can be that the bones become weaker, brittle, osteoporosis. So that can be checked. Cardiovascular risks, if there's any reason to be concerned about the state of the blood vessels, sometimes it can be tested in the neck, looking at if there's any arteriosclerosis. But in general, the treatment principle is, of course, that steroids are very good for the short term, sometimes life-saving for the short term, not so good for the long term. So try to find a better alternative.
Wonderful. I think we have one more question in the chat as well.
From Anne. Are lupus researchers in Europe impacted by the restrictions from GDPR? Are they seeing difficulties to run clinical trials?
Well, that's the data protection rules that apply now everywhere. And they do make things a lot more difficult. But of course, when you do clinical trials, you try to, work with the rules, within the rules. And if it involves having many more safeguards for data protection and privacy, then of course you just do that. But I cannot deny the fact that it makes it a lot harder. And it sometimes also, and that's unfortunate, also prolongs the time before you can get the study done. And we're looking at delays on account of that. So yes, we have some concerns about it. But of course, we will always work within the confines of the rules that apply.
Yeah. Are you working on different ways of doing clinical trials to make sure that you still are following the restrictions, but that it makes it easier?
Well, people are trying to innovate how clinical trials are done, but rules like this don't directly make it harder to do clinical trial. They just tell you that when you're doing the clinical trial, you have to be much more mindful about how the data are shared, who gets access to what data, how they are stored, and things like that. And that is, in and of itself, that is good. What I think is a shame is that if the data from a clinical trial have been used for that clinical trial, and later somebody says, there's something else that you could do with these data that is really, that would really be very useful, analyze them in a different way, look at it in another way. That could be very helpful and important. And that is often made very, very hard by these kind of rules.
Indeed, there's a project called Facilitate that is working on this issue, run out of the University of Birmingham, I believe, that Lupus Europe is, we're starting to learn about. And perhaps help with. Yeah. Thank you.
And I think that was all of the questions. So Anne-Marie, you can continue.
Yeah, thank you, Ronald, for all your answers to the questions. There were a lot of questions. One was for mine because I'm the skin lupus patient. Thank you for your answer. Now, before we go to the breakout rooms, I would like everyone to get started. It doesn't work with my screen. to move. I will start again because
I'll share the videos. It's
do you want to move also, Ronald?
I'll get my exercise, my movement. But thank you very much for inviting me and having me as part of this Congress. And I hope you have a great rest of the day and continue with all the good work that you're doing. Thank you very much.
Thank you for your great presentation. Hope to meet you soon again.
Thank you. Looking forward to it.
Thank you so much.